Imagine, imagine watching your child just stop breathing in their sleep.
Yeah, it's terrifying.
Right. And then the doctors run all these tests. And they tell you, their lungs are perfectly healthy, the tissue is fine, the structures are totally intact, but the breathing just stops anyway.
It's a complete disconnect for a lot of families.
Exactly. For you listening to the parents, the caregivers, the fierce advocates of kids with PURA syndrome, you already know that respiratory failure here isn't usually a problem in the chest. It's, it's a software glitch in the brain.
That's exactly what it is.
And managing that glitch is probably one of the most exhausting, relentless challenges you face. You're the ones, staring at the glow of a pulse oximeter at 3 in the morning.
Calculating oxygen saturations in your head when you're half asleep.
Right. Listening to the rhythm of a CPAP machine. Just constantly hypervigilant against the silence of a missed breath.
It really forces you into a medical role that, frankly, you never trained for.
No, not at all.
You're suddenly expected to understand these intricate neurological mechanisms of the brainstem, manage advanced respiratory equipment, and, anticipate crises before they even happen.
Which is a massive psychological load.
Immense. I mean, breathing is the most fundamental autonomic function we have. When that automatic system is unreliable, the vigilance required to keep a child safe is just superhuman.
Which is exactly why we're dedicating this entire deep dive to really unpacking the clinical reality of those breathing issues.
It's so needed.
Our mission today is to take the clinical guidelines, the latest medical literature, and that targeted research specific to PURA syndrome and kind of, translate them into a concrete, empowering toolkit for you.
Because the information is out there, it just needs to be accessible.
Exactly. So we're going to explore the cellular mechanisms, like why these challenges occur in the first place. We'll break down the differences between central and obstructive sleep apnea.
Which is a crucial distinction.
Huge. And we'll navigate the incredibly high stakes of medical procedures and anesthesia using the OrphanAnesthesia Guidelines.
Yes, the advocacy piece there is vital.
And then finally, we'll map out how this respiratory profile kind of evolves as your child grows and faces new challenges, like scoliosis. So, okay, let's unpack this, because the data actually paints a picture that, while it's super complex, is highly manageable when you understand the mechanics.
It is. And I think the first step is really moving away from the sheer panic of that neonatal period and looking at the structural reality of the condition.
Right. Taking a step back.
Yeah. The literature shows us that while the early days, which are often spent in the neonatal intensive care unit, are intensely challenging, there's a distinct, often positive trajectory.
The breathing can actually stabilize.
It frequently stabilizes.
Right.
But to understand how we get to that stability, we have to look at the foundational genetic architecture first.
Okay, let's go straight to the blueprint then. The literature points to an alteration on chromosome 5, right? Specifically at the 5q31.3 locus.
That's the exact address, yes.
We're looking at a heterozygous pathogenic variant in the PURA gene itself, or maybe a microdeletion that removes the gene entirely, along with some neighboring stuff. But I mean, I want to understand what this specific gene is actually doing. Like, why does a tiny alteration on chromosome 5 cause a child to stop breathing?
Well, to answer that, we have to look at the product the PURA gene creates. It's essentially the manufacturing instruction manual for a protein called PUR-alpha.
PUR-alpha. Okay.
Yeah, and this is a highly conserved, multifunctional protein.
And by highly conserved, you mean it hasn't changed much throughout evolution, right? Like, it's just fundamental to life.
Exactly. We see it in the heart, the skeletal muscles, the blood, but the research heavily emphasizes its role in the brain.
It's like the scaffolding for neurodevelopment.
That's a great way to put it. It's fundamental to the central nervous system. PUR-alpha regulates the proliferation of neural cells. It directs the maturation of dendrites, which are, those branching structures neurons use to talk to each other.
So it's building the communication network.
Yes, and it's heavily involved in binding and transporting messenger RNA to specific sites within the brain so that other essential proteins can be synthesized right there locally.
Wow.
But when we're talking about breathing, if we connect this to the bigger picture, we really have to focus on where PUR-alpha expression is the most dense, and that is the brainstem.
The brainstem, like the absolute primitive core of the brain. The autopilot.
The autopilot is a perfect way to frame it. The brainstem controls all those functions we don't have to think about. Heart rate, blood pressure, temperature regulation, and of course the intrinsic rhythmic drive to inhale and exhale.
So breathing.
Right. Now, PURA syndrome is an autosomal dominant condition, and it's driven by a genetic mechanism called haploinsufficiency.
Okay, walk me through the mechanics of that haploinsufficiency, because every person inherits 2 copies of most genes, right? One from each parent.
Correct.
And in this case, 1 copy is mutated or just missing. So the body's operating on just 1 working copy of the PURA gene. Why isn't that 1 copy enough? Like, can't it just do the job?
You'd think so, but no, because the central nervous system is incredibly demanding. That single working copy is trying its best to transcribe and produce the pure alpha protein, but it simply cannot meet the vast biological quota required to build and maintain a rapidly developing brain.
Oh, so it's just getting overworked.
Exactly. The production is halved. Half is insufficient, hence haploinsufficiency. The brain is essentially operating on a severe pure alpha deficit.
Okay, tracing this back to the breathing then. Because of that severe deficit, the brainstem doesn't construct its neural pathways properly.
Right.
The automatic regulation software is just fundamentally compromised. So when a child with PURA syndrome experiences an apnea, it really is a communication failure.
A total breakdown.
The signal that's supposed to originate in the brainstem and travel down the phrenic nerve to the diaphragm, it's either too weak, or it's totally intermittent, or it just drops out completely.
And that is the absolute core pathology of essential apnea. The lungs are sitting there waiting for an instruction that never arrives.
I'm trying to visualize this communication breakdown for the listeners. It feels a bit like trying to perform a symphony without a conductor.
Oh, let's build on that. That's a great analogy.
Okay.
If the normal respiratory cycle is a symphony, you have 2 distinct elements that have to work in perfect harmony, right?
Right.
First, you have the conductor at the podium. They're setting the tempo, cueing the sections. That is your brainstem.
Got it.
And then you have the musicians in the hall sitting with their instruments, and the doors of the concert hall are open so the music can project out. Those are your respiratory muscles, your diaphragm, and your physical airway.
Okay, so in the case of essential apnea, the musicians are in their seats, the instruments are perfectly tuned, the doors to the hall are wide open, but the conductor, the brainstem, just suddenly lowers the baton and stares blankly at the orchestra.
Yes.
And so no one plays.
That's a perfect representation of a central event.
Yeah.
The physical pathway is completely clear, but the neurological drive is just absent. But the literature reveals that PURA syndrome actually presents a dual threat.
Right, it's not just central apneas.
No, we don't just see central apneas. We also see incredibly high rates of obstructive sleep apnea.
Okay, let's apply the symphony to the obstructive side then. In this case, the conductor is frantically waving the baton. The drive is definitely there.
The signal is firing.
The musicians are trying to play with everything they have, but someone has slammed those heavy oak doors of the concert hall shut. The sound literally can't get out. The airway has physically collapsed.
Exactly. Which creates a phenomenally complex situation for a caregiver. You aren't just managing one type of respiratory failure. You are constantly assessing and reacting to both.
That's so overwhelming.
It is. And the clinical data indicates that more than 50% of infants with PURA syndrome experience these recurrent apneas.
Over half. I mean, that is a brutal reality for a family to face,
Yeah,
especially in those early months when you're already just trying to figure out how to be a parent.
absolutely.
So we've established why the central apnea happens, the pure alpha deficit in the brainstem. But what is driving the obstructive side? Because the airway doesn't just close for no reason.
No, it doesn't. The obstructive apneas are primarily driven by severe oropharyngeal hypotonia.
Okay, so we're talking about low muscle tone, the profound floppiness that is kind of a hallmark of this syndrome.
Yes.
I know parents listening know hypotonia intimately. But the literature makes a very specific distinction here about where this hypotonia comes from and how it behaves.
It does. Hypotonia is present in over 95% of PURA cases, so almost everyone. But it is vital to understand that this low tone is not just affecting the limbs or head control.
It's internal, too.
Very much so. The smooth muscles and soft tissues of the mouth, the palate, the throat, the entire upper airway, they are profoundly hypotonic.
Wow.
And during sleep, our bodies naturally paralyze our voluntary muscles to keep us from, acting out our dreams. But in a child with PURA syndrome, the baseline tone of those airway tissues is already dangerously low.
So when the sleep paralysis sets in?
Gravity just takes over.
Yeah.
The tissues collapse backward, physically occluding the airway. The heavy oak doors shut.
Now, I was looking at how clinicians diagnose this, and I want to explore this really fascinating diagnostic differentiator in the sources. They compare the hypotonia in PURA syndrome to the hypotonia seen in conditions like spinal muscular atrophy, or SMA.
Yes, this is a key clinical distinction.
If a child has SMA, and a doctor taps their knee with a reflex hammer, nothing happens,
Yep.
right? The reflex is absent.
Right, because SMA is a peripheral neuromuscular disorder. The lower motor neurons in the spinal cord, where the actual nerve junctions connecting to the muscles, are physically degrading.
The actual wires are broken.
The peripheral wiring is broken, yes, so the reflex arc cannot complete.
But the sources explicitly state that in PURA syndrome, despite the infant presenting with this profound whole-body hypotonia, the deep tendon reflexes are usually completely preserved.
Yeah.
The doctor taps the knee, and the leg kicks.
What's fascinating here is that this is an enormous clinical revelation. It tells the medical team that the peripheral wiring, the physical connection from the spinal cord to the muscle, is perfectly intact.
The muscles work.
The muscles themselves are fully capable of contracting. The hypotonia is entirely central.
It goes right back to the brain.
It goes right back to the brainstem and the motor cortex. The brain is failing to send that continuous, low-level baseline signal of tightness to the muscles. It's a regulatory failure, not a structural muscular failure.
Knowing that the hypotonia is central, that changes the entire paradigm of how a parent has to view sleep. You're putting your child down for a nap, and you are simultaneously battling the brain's failure to send the breathing signal and the brain's failure to maintain the muscle tension needed to keep the throat open.
It's a dual front.
You are fighting the conductor and fighting gravity at the exact same time.
And that dual battle is precisely why formal sleep studies, polysomnography, are non-negotiable for these children.
You can't just guess by watching them.
Clinical observation alone is totally insufficient. You might see your child's chest heaving, struggling for air, and assume it's entirely obstructive. Or you might see them perfectly still and assume it's entirely central.
But it could be a mix.
Often it is a mixed apnea, a central pause where the drive drops, followed by an obstructive collapse as the body desperately tries to restart the cycle and gasps.
So what exactly are the leads on a polysomnography machine capturing that a parent just can't see with their own eyes?
A lot. Polysomnography provides a complete multi-channel map of the respiratory cycle.
Okay.
The EEG leads on the scalp monitor sleep staging and brain waves, telling us if the brain is even attempting to initiate a breath. The nasal pressure sensors and thermistors measure the actual physical flow of air in and out of the nose and mouth.
So that shows if the doors are open or closed.
Exactly. Then the belts around the chest and abdomen measure respiratory effort or the musicians trying to play. And the pulse oximeter tracks the resulting blood oxygen levels.
That's so much data.
It is, but by aligning all this data, the sleep medicine team can definitively categorize the apneas. Are they 80% central and 20% obstructive? Are they purely obstructive?
And that breakdown dictates the intervention.
Precisely. You cannot effectively treat a complex respiratory profile without knowing the exact ratio of the physiological failures. Furthermore, the sleep study is critical for identifying another major issue mentioned in the literature, which is hypoventilation.
Oh, let's dig into hypoventilation, because this is distinct from an apnea, right?
Yes, very different.
An apnea is a complete cessation of breathing. The music stops completely. But the sources note that individuals with PURA frequently experience periods where they are breathing, but it's just not enough. How does that happen if the airway is open and the brain is signaling?
Well, hypoventilation means the breathing is either abnormally shallow or abnormally slow.
Okay.
The mechanics are working, but the volume of air being moved in and out of the lungs, what we call the minute ventilation, is inadequate.
So they are taking breaths, but they aren't deep enough to properly exchange the gases.
Exactly. Normal respiration is a delicate balance. You bring in oxygen, which binds to hemoglobin, and you exhale carbon dioxide, which is a metabolic waste product.
Right.
In hypoventilation, because the breaths are so shallow, often due to that central hypotonia making the chest wall muscles weak and the diaphragm sluggish, the child simply isn't clearing enough carbon dioxide.
And carbon dioxide buildup in the blood is toxic. It shifts the pH.
Yes, it makes the blood acidic, a state called hypercapnia. And hypercapnia is incredibly dangerous because it further depresses the central nervous system.
Oh no, so it makes it worse.
It creates a vicious feedback loop. The brainstem is already struggling due to the PUR-alpha deficit. Now you bathe it in acidic, high CO2 blood, and it becomes even more sluggish.
Which leads to shallower breathing.
Which leads to more CO2 buildup.
Yeah. So a parent might be watching their child sleep, seeing the chest rise and fall, and thinking everything is totally fine because there are no obvious apneic pauses. But the sleep study actually reveals that the child is slowly accumulating CO2 and starving for oxygen.
Which brings us back to why the neonatal period is so exceptionally perilous. The brainstem is at its most immature, The hypotonia is often at its most severe, and the child's tiny airway offers maximum resistance.
This is what the texts refer to as the neonatal crucible.
Ugh.
We see a classic triad of symptoms right after birth, right?
Yeah.
Severe hypotonia, immediate respiratory insufficiency, and profound feeding difficulties.
That's the triad, yes.
The clinical guidelines map out a very intense intervention timeline for this first year. It sounds terrifying.
It is an aggressive, life-sustaining period. The respiratory insufficiency often dictates weeks or even months in the NICU. We see neonates requiring invasive mechanical ventilation.
Where they actually have a tube down their throat.
Yes, an endotracheal tube is placed, and a machine takes over the work of breathing completely.
The ultimate override of the brainstem.
Yes. For others, continuous positive airway pressure, or CPAP, is sufficient to just stent the airway open and support that respiratory drive. Supplemental oxygen is frequently required to combat the hypoventilation and maintain safe saturations.
And I saw in the texts, in the most severe cases, where the central drive is just catastrophically weak or the upper airway obstruction is completely intractable, tracheostomies have been required.
They have.
A tracheostomy. I mean, that is a massive physiological and psychological shift for a family, creating a surgical airway directly into the windpipe, bypassing the upper airway entirely. It removes the obstructive element, sure, but it requires intensive round-the-clock suctioning and stoma care.
It is arguably one of the most demanding interventions in pediatric medicine, but we really must look at the data surrounding this period because it contains a critical, hopeful pivot.
Okay, good. We need some hope here.
The literature consistently reports that these severe, life-threatening respiratory issues frequently show gradual improvement.
Really?
Yes. For many, they completely resolve after the first year of life.
Okay, wait, I have to challenge this because I'm putting myself in the shoes of a parent listening right now.
Mm-hmm.
We just spent 20 minutes establishing that this is a genetic condition.
Right.
The 5q31.3 locus has a deletion. The PURA gene is permanently altered. The haploinsufficiency is a lifelong biological fact.
It is.
So if the architectural blueprint is permanently missing a page, how on earth does the breathing just get better? Why does the brainstem suddenly figure it out?
It's a profound paradox, I agree, but it is rooted in the difference between a static genetic defect and a dynamic developing nervous system. PURA syndrome is characterized by global developmental delays, but it is fundamentally a non-degenerative condition.
Meaning they don't lose the milestones they gain. They aren't regressing neurologically.
Exactly. The brain is remarkably plastic, particularly in those first 2 years of life. Even with the persistent PUR-alpha deficit, the neural networks are still growing. They are forming new synapses.
They're trying to adapt.
The autonomic nervous system is slowly, painstakingly maturing. The brainstem essentially learns to compensate. It finds alternative pathways or simply matures enough to regulate the basic respiratory drive more consistently.
So the software basically patches itself over time.
It builds workarounds. And simultaneously, we see anatomical maturation. As the child grows, the sheer physical size of the airway increases.
Which helps with the obstruction.
Exactly. The cartilage in the trachea becomes firmer.
Right. The brainstem is the body's thermostat. It regulates when to sweat, to cool down, and when to constrict peripheral blood vessels or induce shivering to warm up. In a PURA neonate, this thermostat is essentially broken. They cannot mount an appropriate metabolic response to cold.
And how does being cold impact their ability to breathe? Like, why does that matter for the lungs?
It initiates a disastrous metabolic cascade. When an infant is cold, they experience massive metabolic stress. They burn through their limited stores of brown fat trying to generate heat.
Okay.
This consumes vast amounts of oxygen and glucose. So now you have an infant whose brainstem is already failing to signal adequate breaths, and their metabolic oxygen demand has suddenly skyrocketed because they are freezing.
Oh, wow.
Furthermore, as their core temperature drops, the respiratory centers in the brainstem become even more depressed. Hypothermia literally slows the central nervous system down, exacerbating the central apneas.
So warming the infant isn't just about comfort, it is a primary respiratory intervention.
Yeah. And this metabolic exhaustion ties directly into the next compounding factor, hypersomnolence.
Excessive, profound sleepiness.
Which, I mean, sounds benign to a parent of a typical newborn who just wants their baby to sleep for 5 minutes. But in this context, it is incredibly dangerous.
It is deeply pathological here. A child who is excessively lethargic is a child who is not taking deep, clearing breaths. Their minute ventilation plummets.
Of hypoventilating.
Yes. They lack the arousal reflex that would normally wake them up if their oxygen levels dropped. Hypersomnolence also prevents the infant from engaging in their environment, which limits the sensory input needed to drive that very neuroplasticity we are relying on for their brainstem to mature.
Wow. And what about the hiccups? The Rare Chromo Guide highlights this, and I thought it was so interesting. Several mothers reported feeling constant rhythmic hiccuping while the baby was still in utero, and it continues aggressively after birth. I think most people view hiccups as just a funny annoyance.
Usually, yes, a hiccup is a myoclonus, an involuntary spasmodic contraction of the diaphragm, followed by a sudden, forceful closure of the vocal cords.
Right.
In a typical adult, it's totally benign. But in an infant with PURA syndrome, persistent, intractable hiccups are a physical manifestation of the central nervous system misfiring.
It's the brainstem again.
It is. The brainstem is failing to coordinate the smooth, rhythmic action of the respiratory muscles. When the diaphragm spasms violently, it disrupts whatever fragile respiratory rhythm the child has managed to establish.
It's like static on the line.
Yes.
But perhaps the most dangerous overlapping symptom the literature presents is the combination of GR, gastroesophageal reflux disease, and severe dysphagia. Swallowing difficulties are reported in over 80% of cases. I want to connect the dots here between the gastrointestinal system and the lungs.
It is a problem of shared real estate and shared neurology.
Yeah.
The anatomical structures used for swallowing are the exact same hypertonic tissues that make up the upper airway. Swallowing safely requires a highly complex, exquisitely timed neurological sequence.
It does.
The airway has to close, the epiglottis has to fold down, the breath has to hold, and the muscles have to propel the liquid past the trachea and into the esophagus.
The suck, swallow, breathe coordination.
Yes. And because of the central hypotonia and brainstem dysregulation, that coordination is shattered. When a child with dysphagia attempts to drink milk, the airway doesn't protect itself in time.
And the milk goes into the lungs.
Milk slips past the vocal cords and enters the trachea. That is aspiration.
And then GERD attacks from the other direction.
Exactly. The lower esophageal sphincter, which is supposed to keep stomach contents in the stomach, is also hypotonic. Acid and digested food freely wash back up the esophagus, spill over the arytenoids, and aspirate into the lungs from below.
Which introduces highly acidic bacteria-laden fluid directly into the delicate alveolar tissue of the lungs,
Leading to aspiration pneumonia. You are causing acute inflammatory damage to the actual tissue of the lungs, which drastically reduces their ability to exchange gas.
So you take a child who already has central apneas, obstructive apneas, and hypoventilation.
And you add damaged, inflamed lung tissue to the mix. It is a catastrophic combination.
That is terrifying.
It is. This is why the clinical threshold for placing temporary nasogastric or NG tubes and eventually permanent surgical G tubes is so low in this population. Bypassing the swallow completely is fundamentally a lung protection strategy.
Okay, we have navigated the neonatal crucible. We understand the biology of the apneas, the structural hypotonia, and the compounding risks of aspiration. Now let's look at the long game. The child reaches age 1, age 2, age 3. The brainstem is maturing. The central apneas are decreasing.
The trajectory improves.
The tracheostomy, if they had one, might even be decannulated. But the literature is explicit here. The vigilance does not end. How do caregivers construct and maintain a safe sleep environment long-term?
Well, the transition out of the acute NICU phase does not mean the child is clinically stable enough to sleep unmonitored.
Right.
Many individuals with PURA syndrome continue to require extensive nocturnal monitoring and support for years.
And the guidelines focus heavily on two specific pieces of technology for the home: continuous pulse oximetry and respiratory rate monitors. Let's break down exactly what these machines are doing, because they catch completely different types of failure.
They do. A respiratory rate monitor, which often utilizes a sensor pad under the mattress or a band around the chest, detects the physical mechanical effort of breathing. It watches for the rise and fall of the thorax.
Okay.
A continuous pulse oximeter, usually a medical-grade sensor wrapped around the toe or finger with an adhesive strap, uses light absorption to measure the heart rate and the peripheral oxygen saturation.
So the exact percentage of hemoglobin in the blood that is actually carrying oxygen molecules. So if a child experiences a central apnea, the brainstem drops the baton, the chest stops moving entirely. The respiratory rate monitor catches that almost immediately, alarming before the residual oxygen in the blood has even been depleted.
Correct. It alerts you to the mechanical failure. But consider the hypoventilation we discussed earlier.
Right.
What happens if the brainstem is signaling and the chest is rising and falling, but the breaths are too shallow to exchange gas effectively?
Oh. The respiratory monitor thinks everything is fine because it feels the physical movement. It doesn't know the breaths are inefficient.
Exactly. And that is where the pulse oximeter becomes the critical safety net. The chest is moving, but the child is slowly becoming hypoxic. The oxygen saturation drops from 98% down to 92, down to 88.
And that's when the alarm goes off.
The pulse oximeter detects that desaturation and alarms, allowing the caregiver to intervene perhaps by repositioning the airway, stimulating the child, or increasing supplemental oxygen.
And the positioning itself is a primary defense mechanism, isn't it? Because that hypotonia doesn't just disappear.
No, it persists, and as the child grows, the positioning becomes vastly more complicated.
How so?
The literature notes that while they start with hypotonia, many children with PURA syndrome eventually develop spasticity, involuntary muscle tightness, or spasms and contractures.
Contractures where the joints become permanently stiffened or fixed in abnormal positions.
Yes, due to the lack of normal movement over time.
So you aren't just positioning a floppy baby anymore. You are trying to safely position a growing child whose body might be actively pulling into asymmetric postures.
Which requires highly specialized sleep systems. Caregivers have to use targeted padding and molded supports to achieve a neutral airway alignment.
Because if the child's turn pulls their chin down toward their chest, the airway occludes instantly.
Instantly. The neck must be slightly extended and supported. They must pad pressure points to prevent skin breakdown over contractured joints and ensure the child is stabilized so a sudden spastic movement doesn't roll them face down into the mattress where they lack the motor control to free their airway.
And for many, this meticulous positioning is supplemented by the machinery of CPAP.
Continuous positive airway pressure. We can think of it as a pneumatic stent.
A pneumatic stent, I like that.
The machine delivers a constant, calculated flow of pressurized air through a mask sealed over the nose, or the nose and mouth. This column of pressurized air physically pushes against the hypotonic tissues of the soft palate and oropharynx, preventing them from collapsing inward when the sleep paralysis takes over.
It holds the heavy oak doors open.
Exactly. It bridges the anatomical gap, and often supplemental oxygen is bled directly into that CPAP circuit to ensure that the air being delivered is rich enough to compensate for any lingering hypoventilation.
So what does this all mean? If we step back and look at what this all means for a family, the nightly routine for a PURA parent is basically equivalent to operating a high-dependency respiratory ward in their own home.
It really is.
You're calibrating the CPAP pressure. You're managing the mask seals to prevent pressure sores on your child's face. You are checking the G-tube venting to ensure reflux doesn't occur while they're supine. You are arranging the skeletal padding. And then you are relying on the pulse oximeter to act as the night watchman, giving you objective clinical data so you can try to get an hour of sleep yourself.
The medicalization of the home environment is profound. It is evidence-based essential care, but it requires relentless operational precision from the caregivers.
Now, we've established the protocol for natural sleep at home, but the stakes change dramatically when we introduce medically induced sleep.
They absolutely do.
The literature is clear that children with PURA syndrome frequently require surgical interventions. We've talked about G-tubes for feeding. They also undergo strabismus correction for eye alignment and major orthopedic procedures like spinal fusions. This brings us to a massive, critical section of our deep dive, the OrphanAnesthesia Guidelines.
This is where parental advocacy becomes literally life-saving.
Tell me about it.
General anesthesia strips away the body's natural compensatory mechanisms. For a child with an already compromised brainstem and a vulnerable airway, it is an environment of extreme risk.
Right.
The OrphanAnesthesia Guidelines were developed specifically to address the unique pharmacological and physiological dangers these rare disease profiles present.
The very first glaring red flag in the guidelines is the hypersensitivity to sedation.
We are primarily discussing opioids, used for pain management, and benzodiazepines, used for preoperative anxiety or seizure control. Patients with PURA syndrome demonstrate an extreme, often unpredictable sensitivity to these classes of drugs.
I'm looking at the mechanism of action here. Opioids bind to mu receptors in the central nervous system. They don't just block pain, they directly depress the respiratory centers in the brainstem.
They do.
In a typical patient, an anesthesiologist expects the breathing to slow down. But in a PURA patient,
The brainstem is already suffering from pure alpha haploinsufficiency. Its baseline drive is incredibly fragile. When you introduce a powerful respiratory depressant like an opioid, you aren't just slowing the breathing down, you risk switching the drive off completely.
Wow.
Furthermore, their bodies exhibit a significantly delayed clearance of these medications. The drugs linger in the central nervous system far longer than pharmacokinetic models predict for a neurotypical child.
So what is the clinical directive? How does the anesthesiologist manage the pain without stopping the breathing?
The OrphanAnesthesia Guidelines mandate a drastic dose reduction.
How much?
The recommendation is to reduce the standard dose of respiratory depressants by approximately 50%.
Half the dose.
Yes. The anesthesiologist must titrate the medications incredibly slowly, using short-acting agents whenever possible, and continuously monitoring the clinical response rather than relying on standard weight-based dosing formulas.
This pharmacological reality brings us to a scenario that I know a lot of parents face, and it requires fierce advocacy. The concept of day surgery or ambulatory surgery.
The quick outpatient procedure. You arrive at 7 in the morning, the procedure takes an hour, they observe the child in recovery for 2 hours, and you are discharged home by lunchtime.
I am reading the guidelines right now, and I want to speak directly to the parents listening. If you are sitting in a pre-op consultation and an unfamiliar surgeon or anesthesiologist suggests that a G-tube replacement or a quick dental procedure under general anesthesia can be done as a day surgery, this is where you pull out the orphan anesthesia literature and stop the conversation.
The guidelines are unequivocal. Ambulatory surgery is strictly contraindicated for patients with PURA syndrome. It is too dangerous.
Because of that delayed clearance we just talked about.
Exactly. The child might look perfectly stable in the post-anesthesia care unit at hour 2. Their oxygen saturations are 98%, they are breathing comfortably, and the team clears them for discharge.
And then they go home.
But because their central nervous system clears the drugs so slowly, the lingering respiratory depressants can cause a catastrophic central apnea or severe hypoventilation at hour 8 or hour 12, long after they have gone home to a less monitored environment.
So what is the mandatory protocol?
Following any procedure requiring general anesthesia, the guidelines demand admission for a mandatory 24-hour continuous monitoring period.
A full day.
This means formal hospital admission with continuous pulse oximetry and respiratory rate monitoring to observe for late-onset recurrent apneas or desaturations.
And the risks aren't just pharmacological. The guidelines heavily emphasize the extreme vulnerability of the physical airway during the perioperative period.
Due to the severe oropharyngeal hypotonia and the high prevalence of dysphagia, there is a massive risk of aspiration and complete upper airway obstruction.
At points.
This risk peaks at 2 distinct moments. First, during induction, as the child is losing consciousness and their baseline tone completely vanishes. And second, during emergence, as they are waking up but do not yet have the motor control to clear their own secretions or support their own palate.
How does the anesthesia team protect them during the wake-up phase? They can't leave the breathing tube in forever?
No, they can't. The guidelines recommend the prophylactic use of nasopharyngeal airways during emergence.
What's that?
This is a soft, flexible rubber tube that is lubricated and inserted through the nostril, extending down into the posterior pharynx. It physically stents the floppy tissues open, bypassing the tongue and palate collapse, providing a secure column of air until the child is fully awake, alert, and has regained their maximum baseline muscle tone.
There are 2 more massive compounding variables the anesthesiologist has to manage, both of which tie back to our earlier discussions. First, thermoregulation. Operating rooms are notoriously freezing.
And we know these patients have autonomic dysfunction and cannot regulate their core temperature. Hypothermia in the OR will drastically delay the metabolism of the anesthetic drugs and increase the risk of postoperative apneas.
So they have to keep them warm.
Active, aggressive warming measures are required. Forced air warming blankets, fluid warmers for the IV lines, and continuous core temperature monitoring must be utilized from the moment they enter the suite.
And second, seizures. The literature indicates that over 50% of PURA patients suffer from complex, often refractory epilepsy.
This raises an important question regarding seizure management on the day of surgery because it presents a massive logistical challenge.
You're right. Because of the MPO rule, nothing by mouth past midnight. You cannot have food or liquid in the stomach because of the risk of aspiration under anesthesia. But these children take powerful, carefully calibrated anti-epileptic drugs every single day.
Yes. The strict guideline is that the seizure management must not be interrupted. Perioperative seizures drastically complicate recovery. They exponentially increase the brain's demand for oxygen. They require emergency doses of rescue diazepines, which we just established are incredibly dangerous for their respiratory drive, and they vastly increase the risk of aspiration.
So if they are NPO, how do they get their meds?
The medical team must proactively calculate and administer intravenous substitutes for the patient's daily oral anti-epileptic regimen.
Through the FOI.
Yes. The therapeutic blood levels must be maintained seamlessly. A seizure during recovery from anesthesia in a PURA patient is a respiratory crisis waiting to happen.
It is a masterclass in systemic physiology.
Hmm.
You cannot touch the lungs without managing the brainstem, the temperature, the seizures, and the pharmacology.
Everything is connected.
Which actually leads us perfectly into the final phase of our deep dive. Because as the child survives the neonatal period, and as they grow and the central drive stabilizes, the respiratory threat physically relocates.
It does.
It shifts from the software of the brainstem down into the physical hardware of the chest cavity.
This represents a critical transition in the natural history of PURA syndrome. As we move into later childhood and adolescence, we have to look at the devastating compounding effects of chronic hypotonia on the skeletal system.
We're talking about the spine. The literature reports that scoliosis, a lateral curvature and rotation of the spine, occurs in roughly 48% of the PORA population, half of all patients.
And to understand why that happens and why it is fundamentally a respiratory issue, we have to connect the gross motor delays to the skeletal architecture.
Okay.
A typically developing child is sitting, pulling to stand, and walking within their first 18 months. Those actions are not just developmental milestones, they are structural imperative.
They build the body.
Exactly. When a child stands, gravity pushes down on the spine and the core muscles constantly fire and pull against the bones to keep them upright.
That dynamic tension is what builds bone density and tells the vertebrae how to stack vertically.
Yes, it is dynamic weight-bearing. But a child with PURA syndrome experiences profound motor delays. Independent ambulation is often not achieved until between 3 and 10 years of age, if it is achieved at all.
So they spend years lying supine or supported in seated positions without that gravitational force moving vertically through the spine.
Yes. And the paraspinal muscles, the muscles that run along the back to support the vertebrae, are profoundly hypotonic. They lack the strength and tension to hold the spine in alignment.
So what happens?
Without the internal muscular support and the external dynamic weight-bearing, the spine begins to collapse under the forces of gravity. It curves sideways and twists.
And here's where the orthopedics violently collides with the respiratory system. Walk me through the mechanics of how a curved spine destroys lung function.
Let's visualize the chest cavity, the rib cage, as a bellows. To take a deep, effective breath and clear carbon dioxide, those bellows need to expand outward and downward symmetrically. But the ribs are attached directly to the thoracic spine. When the spine develops a severe scoliotic curve and rotates, it takes the rib cage with it. The ribs on the inside of the curve become severely crushed together and compressed.
Which physically traps the lung tissue inside that collapsed space.
Precisely. The lung on the concave side of the curve cannot inflate. The physical volume of the chest cavity is restricted. This creates a restrictive lung disease profile. The child is forced back into hypoventilation because they literally do not have the physical space to expand their lungs.
That's heartbreaking.
And furthermore, because the bellows are broken, they cannot generate the forceful pressure required to produce an effective cough.
And without an effective cough, they cannot clear the normal daily respiratory secretions, let alone fight off a cold.
The secretions pool in the compressed areas of the lung, creating a perfect breeding ground for bacteria. This leads to recurrent, severe pneumonias, further damaging the lung tissue and exacerbating the restrictive disease.
And the research indicates that it's not just the shape of the spine, it's the structural integrity of the bones themselves.
Bone health is a massive, compounding vulnerability. Low bone mineral density is ubiquitous in this population, leading to osteopenia and eventually early-onset osteoporosis.
Why is that?
The etiology here is highly multifactorial. The lack of dynamic weight-bearing fails to signal the bones to mineralize. We also see pervasive reports of low vitamin D levels in the PURA population.
Oh, interesting.
And crucially, many of the long-term anti-epileptic medications required to manage their seizures are known to actively interfere with bone metabolism.
The bones are structurally weak, they're lacking the muscular scaffolding to stay straight, and as they warp, they crush the lungs. This completely upends how a parent has to think about respiratory therapy. If I have a 10-year-old with PURA syndrome, Protecting their breathing isn't just about adjusting the CPAP pressure anymore.
It becomes an aggressively orthopedic endeavor.
Utilizing standing frames to force weight bearing through the long bones and spine. Committing to aggressive, daily physical therapy to build whatever core strength is neurologically possible. Diligently monitoring vitamin D levels and pushing supplementation.
Yes.
Getting regular, specialized spinal x-rays to track the Cobb angle of the curvature. These are not just physical therapies. They are direct, proactive respiratory treatments. Because if you protect the architecture of the spine, you protect the volume of the lungs.
That is the exact clinical paradigm shift required. And in many cases, despite these aggressive, conservative measures, the scoliosis becomes progressive. The curvature worsens to the point where it threatens fatal pulmonary compromise.
So what's the last resort?
At that juncture, major surgical intervention, a spinal fusion, where rods and screws are used to manually straighten and lock the spine in place, becomes necessary simply to save the lungs.
Which terrifyingly brings the family right back to the surgical and anesthetic risks we just unpacked. It is a lifelong, incredibly complex cycle of anticipating the mechanical failures of the body and manipulating the environment to keep the child alive.
It is. But I want to synthesize exactly what we have covered today, because the knowledge we've discussed is the very tool that breaks the panic of that cycle. We have mapped a monumental journey.
We really have.
We started with an acute neurological crisis in the NICU, battling the microscopic reality of a pure alpha deficit in the brainstem. We moved through the relentless, exhausting nightly routine of pulse oximetry, managing the pneumatic stent of CPAP, and fighting the gravity of hypotonia to achieve safe sleep.
Yeah.
We've shown you how to weaponize the OrphanAnesthesia Guidelines to protect your child during surgery, and we've mapped the transition into aggressive orthopedic management to protect the physical space of the lungs.
It is an overwhelming amount of medical data. But the power in this deep dive is the trajectory. The statistics sound daunting, but the overwhelming narrative in the literature is one of stabilisation. The condition is non-degenerative.
Exactly.
The brainstem does mature, the airway does grow. The global medical community, driven by advocacy groups and incredible parents, is mapping these specific protocols. You aren't operating in the dark.
You have the data, you have the guidelines, you understand the why behind the what, which transforms you from an anxious bystander into a critical part of the clinical team.
And as we close, I want to leave you with a final provocative thought to mull over. Everything we've discussed today, the CPAP, the oximeters, the standing frames, the spinal fusions, it is all supportive care. It is managing the symptoms of the software glitch. But the research pipeline is moving at a staggering pace. In 2025, a landmark collaboration between researchers at the Jackson Laboratory and the Florey Institute successfully developed CRISPR-Cas9 knockout mouse models.
Which is a monumental leap. These models exhibit the precise foundational features of PURA syndrome. They are the exact biological replicas required to test actual targeted gene therapies.
And those therapies are entering the pipeline now. So here's the thought I want you to hold on to.
Right.
If these future treatments can successfully cross the blood-brain barrier, target the central nervous system, and restore the production of pure alpha protein in the brainstem, could we see a day where we stop treating the symptoms entirely?
It's a real possibility.
If the software glitch is fundamentally patched to the cellular level, could we allow the child's brainstem to finally instinctively remember how to breathe on its own? It is a profound, incredibly realistic hope for the future of respiratory care in PURA syndrome. Until that day arrives, you have the monitors, you have the guidelines, and you have the fierce, unyielding knowledge to keep them safe.